Welcome to eNormous Nephrology, where we're beginning with the eight sessions of board review, followed by short sessions on individual topics of wide interest and that are stimulating to the mind. The purpose is to generate energy and enthusiasm for nephrology amongst upcoming physicians and to sharpen knowledge base for established physicians. This session, next slide. This session is geared towards acute kidney injury and chronic kidney disease and the various individual etiologies that are usually seen in the acute kidney injury scenario and in the CKD scenario. So when you have acute kidney injury, you want to think pre-renal, intrarenal, or post-renal. In the intrarenal compartment, you want to think about glomerulus, tubules, interstitium, and blood vessels. It's easy to remember all the different etiologies in the differential by compartmentalizing it this way. And you won't forget anything when you're examining a patient or talking to a patient and developing a differential. Next slide. So this is the way, these are all the different things that should run through your mind as you're evaluating a patient with acute kidney injury. Pre-renal etiology is by far the most common etiology that you will see in the clinical setting. And we all know that you will see patients with volume depletion, whether it's because of overdiuresis, GI losses, or even renal salt wasting, or adrenal insufficiency, which is also a cause for pre-renal azotemia. Patients with congestive heart failure, cirrhosis, third spacing, nephrotic syndrome are also pre-renal patients who are whose perfusion is not optimal because of the underlying etiology. Renal artery stenosis, of course, impairs perfusion of the kidneys, and in shock you will have hypotension and impaired perfusion of the kidneys. In the intrarenal compartment, you want to think about glomerulus, tubules, interstitium, and the vascular compartment. A lot of these I'm going to be discussing in detail in subsequent sessions, so I will merely make mention today, and we will be talking about ATN. So in the glomerulus, you will have antiglomerular basement membrane, post-immune glomerulonephritis, and immune complex glomerulonephritis, which would be lupus, post-infectious, IgA nephropathy, membranoproliferative glomerulonephritis, or cryoglobulinemia. In the tubular compartment, the most common thing you will see is acute tubular necrosis, ischemia, and then nephrotoxic agents, which is intravenous contrast, NSAIDs, or vancomycin. Myeloma kidney affects the tubules. Rhabdomyolysis, which is pigment-induced injury to the tubules, should also be remembered. It's easy to check a CPK and determine if there's excessive myoglobin in the blood, which is the cause of acute kidney injury. Crystalluria, we always think about kidney stones, but even crystals are a cause of acute kidney injury. And then tumor lysis. In the interstitial compartment, you want to think about interstitial nephritis. So you always want to ask the patient, are you taking any herbal medications? Are you taking any over-the-counter medications? So medications are a common cause of interstitial nephritis, but infection itself can cause interstitial nephritis. Immune disorders and cancer is another cause of interstitial nephritis. Of course, sarcoidosis, and then the Tenu syndrome, which is tubular interstitial nephritis with uveitis, should always be in the back of your mind. In the vascular compartment, you have emboli, whether it's because of atrial fibrillation or for some other reason, antiphospholipid antibodies, cholesterol emboli, as in instrumentation, whether it's a cardiac cath or something else that triggers cholesterol emboli, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, cortical necrosis, malignant hypertension, scleroderma renal crisis, eclampsia, and polyarthritis nodosa. All of these will be discussed separately in detail in individual sessions. Postrenal is probably the second most common etiology that you will see in the clinical setting. Bladder outlet obstruction, whether it's because of bladder cancer, prostate cancer, kidney stones, even neurogenic bladder in the setting of diabetes or other neurogenic etiologies. Obstructed Foley. If the Foley is obstructed, obviously you're going to have obstruction and hydronephrosis. You can have bilateral urethral obstruction, although urethral obstruction is commonly seen unilaterally. And then if you have a solitary kidney for whatever reason, a stone, tumor, clot, extrinsic compression, retroperitoneal fibrosis, or papillary necrosis can cause hydronephrosis of that solitary kidney. Next slide. So my way of stimulating thinking and to prevent boredom is to intersperse my talk with questions. I think that's a very interesting way of learning, because not only do you have to learn content and retain it, but you also have to apply it, and application stimulates retention. So you're consulted regarding a 50-year-old man with type 2 diabetes for evaluation of his acute kidney injury. He has been treated with pioglitazone for the past 1 year. He has been meticulous in his self-care. His blood pressure control has been an ongoing problem, and he recently had telmisartan added to his regimen of metoprolol, ramipril, and hydrochlorothiazide. His serum creatinine had been stable at 1 milligram per deciliter 2 months ago, but was noted to be 1.8 milligram per deciliter at his most recent follow-up visit. He reports a cold for which he took a non-steroidal anti-inflammatory drug for 2 days 2 weeks ago, but no other new events. His physical examination reveals a body mass index of 26, and his blood pressure is 118/60. His laboratory results show an A1C of 7.1. His urine dipstick for albumin is negative at this time. Which one of the following is the most likely cause of his AKI? Non-steroidal anti-inflammatory drug use, extracellular fluid volume depletion, progression of his diabetic nephropathy, antihypertensive medication, or pioglitazone toxicity. He did use non-steroidal anti-inflammatory drug for 2 days, but that is unlikely or less likely to be the cause of his acute kidney injury, because use of non-steroidals is typically persistent and prolonged in order for it to cause AKI. However, single or even short-term use of NSAIDs can sometimes cause proteinuria, proteinuria but is a different problem. There's no evidence that there's extracellular fluid volume depletion here, and progression of his diabetic nephropathy would require more data, and his A1C currently is 7.1. The combination of ACE inhibitor and ARB is not recommended, and that is likely to be the answer for this question. Next slide. You're asked to see a 65-year-old woman with stage 3B A3 chronic kidney disease from diabetic kidney disease and chronic systolic heart failure in consultation 1 week in advance of elective coronary angiography. Medications are metformin, simvastatin, lisinopril, chlorthalidone, and aspirin. A physical examination shows a blood pressure of 132/80 millimeters of mercury. There is trace ankle edema. The remainder of the examination is normal. Laboratory studies show sodium of 138, potassium 5.2, chloride 104, bicarb 23, BUN of 32, creatinine 1.9 milligram per deciliter, and eGFR of 32 milliliters per minute per 1.73 meters squared. Which one of the following is the best management recommendation? So this patient is going to have elective coronary angiography. How would you avoid contrast-induced nephropathy in a patient with GFR of 32? Would you discontinue metformin 2 to 3 days before the contrast? discontinue lisinopril 1 day before the contrast, make no changes to the current medication regimen, or discontinue chlorthalidone. Next slide. So we're going to review the guidelines by the American College of Radiology and the National Kidney Foundation. Next slide. So this is obviously a common situation, and this is a dilemma we all face. And how do we approach it? So the true risk of contrast-induced AKI remains uncertain for patients with severe kidney disease. Prophylaxis with intravenous normal saline is indicated for patients who have AKI or an estimated glomerular filtration rate less than 30 milliliters per minute per body surface area who are not undergoing maintenance dialysis. So the question stated a GFR 32. So that's pretty much close to high risk kidney disease. In individual high risk circumstances, prophylaxis may be considered in patients with GFR of 30 to 44 at the discretion of the ordering clinician. When prophylaxis is indicated, normal saline is the preferred method. The timing, volume, and rate of volume expansion is uncertain, but volume expansion regimens begin 1 hour before and continue 3 to 12 hours after contrast administration, with typical doses ranging from fixed to weight-based volumes. Longer regimens have been shown to lower the risk of contrast-induced nephropathy better than shorter regimens. However, obviously longer intravenous protocols are generally impractical in the outpatient setting. And oral hydration has not been well studied. Next slide. In patients with acute kidney injury or GFRs less than 30 milliliters per minute per body surface area, it may be prudent. So the key is it may be prudent to withhold non-essential potentially nephrotoxic medications such as NSAIDs, diuretics, aminoglycosides, amphotericin, cisplatin, zolitronate, methotrexate, if it's clinically feasible for 24 to 48 hours before and 48 hours after exposure. In one study in patients with congestive heart failure, achieving dry weight before contrast administration was shown to reduce the risk of contrast-induced nephropathy. In this study, both weight excess and weight deficiency were associated with increased risk of contrast-induced nephropathy. Our patient was reported to have some edema, so holding the chlorthalidone is probably not the best answer. Next slide. Should you hold RAS inhibitors? That's a controversial area, and there's conflicting data. A meta-analysis of 12 studies and 4,500 patients found no difference in risk of contrast-induced nephropathy between patients receiving and patients not receiving RAS inhibitors. However, in stratified analysis, there was an increased risk of contrast-induced nephropathy for chronic RAS inhibition users and not for new RAS inhibition users. Given the lack of strong evidence demonstrating that continuing RAS inhibition is beneficial, referring clinicians should consider withholding RAS inhibitors in patients at risk for at least 48 hours before elective contrast-induced CT to avoid the potential for hypotension and hyperkalemia should contrast-induced nephropathy develop. RAS inhibitors may be restarted if contrast-induced nephropathy does not occur or following the return of kidney function to baseline. Next slide. Metformin does not increase the risk of contrast-induced nephropathy. If contrast-induced nephropathy developed in a patient receiving metformin, then the risk of lactic acidosis is increased. Therefore, the recommendation is that metformin should be withheld in patients with AKI or GFR less than 30, consistent with US FDA recommendations to generally avoid metformin at this level of kidney function. Although the FDA also recommends withholding metformin prior to iodinated contrast media exposure for GFR 30 to 59, decision-making should be individualized by referring clinicians at this GFR level because the risk of contrast-induced nephropathy is sufficiently low. Therefore, the best answer is to hold metformin before contrast in line with FDA recommendations. The other medications can be held and may be prudent to hold, but definitely metformin should be held. Next slide. You're admitting a 65-year-old kidney transplant recipient with presumed urosepsis. The patient is confused, disoriented, and hypotensive with a blood pressure of 90/55. The temperature is 39.1 degrees Celsius. The oxygen saturation is 88% on ambient air. The oxygen saturation increases to 93% after initiation of oxygen at 4 liters per minute by nasal cannula. Laboratory studies show serum sodium 132, potassium 3.6, chloride 95, bicarb 18, UN 18, creatinine 1.4 milligram per deciliter, increased from 1.1 milligram per deciliter 3 months ago. Leukocyte count 15.2, hemoglobin 6.8, and platelet count 126,000. Which one of the following is the most important step in mitigating this patient's morbidity and mortality in the setting of impending septic shock? Administration of a bolus of 30 cc's per kg of normal saline, administration of vasopressors to achieve a MAP 70 millimeters of mercury, administration of a combination of fluids and vasopressors to achieve a target central venous saturation of 70%, early administration of appropriate antibiotics. Next slide. In sepsis, bolus of 30 cc's per kg is the single most important step in mitigating morbidity and mortality. In reality, antibiotics and pressors may be concomitant. Next slide. A 67-year-old woman with chronic systolic heart failure and stage 3A A1 CKD is evaluated for persistent congestive symptoms despite recent initiation of furosemide 2 weeks ago. Despite the first week after initiation of furosemide, the weight decreased by 4 kilograms. During the first week after initiation of furosemide, the weight decreased by 4 kilograms. Over the past week, however, her weight has remained stable and she continues to have orthopnea and dyspnea on exertion. Medications are furosemide 40 milligrams daily, lisinopril 30 milligrams daily, and spironolactone 25 milligrams daily. On physical examination, the blood pressure is 115/80, the pulse is 68, the jugular venous pressure is 8 centimeters of water, there are bibasilar crackles and 2+ leg edema. Laboratory studies show sodium of 134, potassium 5.0, chloride 96, bicarb 28, UN of 34, and creatinine of 2.1 milligram per deciliter, increased from 1.8 milligram per deciliter 2 weeks ago. A urinalysis shows no protein cells or casts. In addition to ongoing assessment of this woman's serum electrolytes and kidney function, which one of the following is the most appropriate next step in management? Discontinue furosemide, discontinue lisinopril, increase furosemide to 80 milligrams per day, or increase furosemide to 40 milligrams twice daily. Obviously, discontinuing furosemide is not appropriate. This patient has orthopnea and dyspnea on exertion and is in volume excess. Discontinuing lisinopril is also currently not appropriate. So the question is, would you increase the furosemide to 80 milligrams per day or to 40 milligrams twice daily? Next slide. So patient is clearly volume overloaded. Twice daily dosing is considered better because it avoids diuretic-free intervals. In fact, increasing the frequency to 3 times a day may be even better because you are avoiding intervals in which the patient is free of diuretic. So the answer is to change to twice daily dosing. Let's talk about chronic kidney disease. Chronic kidney disease implies that there has been some damage to the kidneys and there's some degree of fibrosis. We don't always prove how much fibrosis there is because you would have to do a kidney biopsy to prove that. But the fact that the GFR remains at a certain level in a certain range is used as evidence that chronic kidney disease exists. The most common causes of chronic kidney disease are diabetes in 30 to 40% of patients, followed by hypertension in 20 to 30% of patients, chronic glomerulonephritis or chronic tubular interstitial disease, followed by polycystic kidney disease, obstructive neuropathy, and ischemic nephropathy. Next slide. Classification of chronic kidney disease is widely known. I'm going to quickly go through the different levels. Normal GFR is greater than 90 milliliters per minute per body surface area. Stage 2 chronic kidney disease is 60 to 89. Stage 3A is 45 to 59. 3B is 30 to 44. Stage 4 is 15 to 29 milliliters per minute per body surface area. And stage 5 is less than 15 milliliters per minute per body surface area. A1 implies that there is minimal albuminuria, that's less than 30 milligrams. A2 implies that the albuminuria is between 30 to 300 milligrams, previously known as microalbuminuria, but the term microalbuminuria is no longer being used. And A3 implies greater than 300 milligrams of albumin in the urine per 24 hours, or as a ratio of albumin to creatinine in the urine. Next slide. So let's talk about diabetic kidney disease. How do you diagnose diabetic kidney disease? The traditional definition of diabetic kidney disease was as follows. If you had type 1 diabetes mellitus, so you had 10 years of type 1 diabetes mellitus and impaired GFR, that was sufficient to diagnose diabetic kidney disease. If you had type 2 diabetes mellitus and you had macroalbuminuria or albumin to creatinine ratio of greater than 300 milligrams per gram or 300 milligrams per 24 hours, that was consistent with the diagnosis of diabetic kidney disease. If you had microalbuminuria or urine albumin to creatinine ratio of 30 to 300 milligrams per gram or 30 to 300 milligrams per 24 hours, and you had diabetic retinopathy, and some people use other sequelae of diabetes, such as peripheral neuropathy, coronary artery disease, peripheral vascular disease, then you can be reasonably certain that the chronic kidney disease is due to diabetes. However, it is being increasingly recognized that diabetic kidney disease can occur in non-proteinuric CKD. Many studies have shown that biopsy-proven diabetic glomerulosclerosis can occur in patients without proteinuria. Progression of DKD, diabetic kidney disease, can occur even if diabetes is well controlled. So the first step is to control diabetes. But even after diabetes is controlled, because of the abnormality in the metabolic axis, progression of diabetic kidney disease still can occur and does occur. Next slide. Does everybody with diabetes develop chronic kidney disease? No, but about 40% of diabetics will develop diabetic kidney disease. So why do some people develop diabetic kidney disease and other people do not? Susceptibility to developing diabetic kidney disease, of course, it would have to do with poor diabetes control or concomitant hypertension, but it is also partially genetically determined. So in discussing pathology, what happens is that you have persistent hyperglycemia that's going to increase glomerular capillary pressure and lead to mesangial expansion. Elevated glucose also will bind everything and create havoc. So these are called advanced glycosylation end products. And these advanced glycosylation end products are the reason for stimulation of TGF-beta and resultant fibrosis. Angiotensin II is elevated in diabetic kidney disease and is thought to constrict the efferent arteriole, leading to glomerular hypertension. And glomerular hypertension is a problem in many chronic kidney etiologies, including hypertension and other causes of chronic kidney disease. Angiotensin II also stimulates TGF-beta and promotes fibrosis. So when you look at the kidney biopsy, you're going to see mesangial expansion, mesangial sclerosis, and in advanced disease, you'll see Kimmel-Steele-Wilson nodules. Next slide. DKD prevention is very important. ACE/ARBs should be used in patients with albuminuria regardless of blood pressure. Strict adherence to dietary recommendations, exercise recommendations. Weight loss is helpful. Ophthalmology visit every 6 months to a year. Annual podiatry evaluation. The feet should be examined at every primary care visit. And of course, you must treat hypertension because the combination of diabetes and hypertension is doubly dangerous. Next slide. So treating diabetes is actually now partly in the nephrology realm, although we still rely mostly on endocrinologists and primary care physicians to help us with treatment of diabetic kidney disease. If your GFR is greater than 60 with albuminuria, and albuminuria is actually an independent definition of chronic kidney disease. So even if your GFR is normal and you have albuminuria, then you have chronic kidney disease. So in these patients, SGLT2 inhibitors are recommended, independent of A1C, and association with metformin is recommended. If your GFR is 30 to 44, again, SGLT2 inhibitors associated with metformin is recommended, you should reduce the metformin dose according to GFR dose adjustments. If your GFR is 15 to 29, you can still use SGLT2 inhibitors, although some nephrologists will not use SGLT2 inhibitors below 20 milliliters per minute per body surface area. And obviously at this GFR, metformin and sulfonylureas are not recommended. You should add GLP-1 receptor agonists, especially if albuminuria or obesity is present. And then controlling diabetes is the most important. So additional anti-diabetic agents or insulin should be used as appropriate. If your GFR is less than 15, SGLT2 inhibitors should not be used. And of course, metformin and sulfonylureas are not recommended. So treatment of diabetes at this point will mainly be driven by endocrinology and primary care. Next slide. So the one important thing about SGLT2 inhibitors is to recognize the adverse effects. SGLT2 inhibitors will increase urine output, will lower the blood pressure a little bit, and will cause predisposition to urinary tract infections and genital infections, as well as wound infections in people with wounds or skin breakdown. So if your patient already has hypotension, or you think the patient at that stage is hypovolemic, then you should not initiate SGLT2 inhibitors. If you're normotensive or hypertensive or euvolemic or hypervolemic, then you should initiate SGLT2 inhibitor at the lowest dose and up titrate as tolerated. What do you do if the patient has an A1C that's at target, like around 7.0? You should reduce the dose of sulfonylurea or meglitinides by 50% and then start the SGLT2 inhibitor. Next slide. So a 58-year-old man with stage 3A, A3 CKD, secondary to diabetic nephropathy, is evaluated during a routine follow-up visit. His medications are lisinopril 40 milligrams daily, atorvastatin 40 milligrams daily, and metformin 500 milligrams twice daily. On physical exam, the blood pressure is 128/85. The remainder of the exam is unremarkable. Home blood pressure readings average 128/80. Laboratory studies show a hemoglobin A1C of 7.1 and a GFR of 48 milliliters per minute per body surface area. The urine albumin to creatinine ratio is 420 milligram per gram, clearly above goal. the addition of which one of the following interventions is the most likely to delay progression of chronic kidney disease? Would you use losartan? So the patient is already on lisinopril 40 milligrams daily. So a combination of ACE inhibitor and ARB is not recommended. And SGLT2 inhibitor with the latest surge in data should be used to prevent progression of CKD. So SGLT2 inhibitor is actually now being touted as indicated for prevention of progression of chronic kidney disease, even if you don't have albuminuria, even if you don't have diabetes. So aside from proteinuria and diabetes, progression of CKD, regardless of etiology, is thought to be an indication for SGLT2 inhibitor. Next slide. A 57-year-old man with type 2 diabetes and hypertension is evaluated in follow-up care for stage 3A, A3 CKD. He was recently prescribed empagliflozin by his primary care physician after his A1C level was found to be 7.9. He's asymptomatic. The blood pressure is 128/82. He has no edema. Laboratory data shows GFR 54, urine albumin to creatinine ratio of 350 milligram per gram. He's concerned about the adverse effects of empagliflozin, especially in the setting of pre-existing kidney disease. Which one of the following should you tell him about potential adverse events related to treatment with SGLT2 inhibitors? Amputation has been reported with all SGLT2 inhibitors. That's not true, usually in the setting of wound or skin breakdown. The risk of genital infections is higher. There is no risk of acute kidney injury. Even though currently there is no evidence that SGLT2 inhibitors do not cause acute kidney injury, SGLT2 inhibitors should be held during acute kidney injury. The data at this point is probably not complete, so this statement should not be made. The risk of hypoglycemia is increased. The risk of hypoglycemia is not increased unless the patient is on other anti-diabetic medications. So the answer is that the risk of genital infections is higher. Next slide. So just to summarize, caveats of SGLT2 inhibitors: urine output may increase, and so you should monitor weights and monitor for dizziness. Blood pressure may be lower. Again, monitor for low blood pressure and dizziness. Do not use in diabetes mellitus type 1 because of the risk of diabetic ketoacidosis. Impaired wound healing does occur, so hold if you have skin breakdown. And if you have propensity towards UTIs, proper hygiene is indicated, and you should avoid SGLT2 inhibitors if you have dysuria, recurrent UTIs, redness or itching in the genital area, foul-smelling vaginal or penile discharge, and if there is a genital infection that's present. Acute kidney injury has not been reported. However, SGLT2 inhibitors must be held during acute kidney injury. Next slide. Let's talk about hypertensive kidney disease. Most of us don't realize that essential hypertension should only be made as a diagnosis after all the secondary causes are ruled out. Normally, we think of secondary causes as primary aldosterones and pheochromocytoma and renal artery stenosis, but chronic kidney disease is actually a secondary cause of hypertension. Insulin resistance itself is a secondary cause of hypertension. Obstructive sleep apnea is a very common etiology that gives rise to hypertension. Corticosteroid excess, thyroid disease, and hyperparathyroidism. If you have chronic kidney disease and you have hyperparathyroidism, then that is usually causative of hypertension. And then, of course, NSAIDs, pseudoephedrine, and illicit drugs. Next slide. So I'm going to briefly mention low-renin essential hypertension because this is actually an important etiology to remember. And subsequently, I will devote an individual full session to low-renin essential hypertension. Low-renin essential hypertension or low-renin hypertension comprises about 20 to 30% of all hypertensive patients. So if it only comprises 20 to 30% of hypertensive patients, why should we worry about low renin hypertension? Because almost 70 to 80% of difficult to control hypertension or resistant hypertensives are low renin hypertension, low renin essential hypertension. So low renin essential or low renin hypertension implies that the renin level is low, and the most common cause of low renin hypertension is low renin essential hypertension. The traditional cutoff for low renin hypertension is a plasma renin activity between 0.65 to 1 nanogram per milliliter per hour using an enzyme kinetic assay. The most frequent form of low renin hypertension is essential hypertension. The remainder are secondary and genetic subtypes, which I will not discuss here. And in the distant past, low renin hypertension was thought to be benign, but of course it does increase cardiovascular risk. Next slide. The most important thing to remember about low renin essential hypertension is that it most likely has a sodium volume dependent hypertension. So, and people who eat salt do have low renin essential hypertension. Natriuresis, or getting rid of sodium, is actually a concerted approach and a very effective approach in controlling blood pressure. Next slide. Of course, we know that thiazide diuretics and loop diuretics have natriuretic effects, and aldosterone receptor antagonists have natriuretic effects, but some of us don't know that the calcium channel blockers, which induce renal vasodilation, also inhibit tubular sodium reabsorption, in addition to causing natriuresis. Next slide. There are certain age-race subgroups that have been shown in hypertension studies. The one that I try to remember is that younger Caucasians, less than 55 years, tend to have higher renin levels than older and Black individuals of African descent. And in these patients, it may be prudent to start off with RAS inhibition or beta blockers. Next slide. And the British Hypertension Society uses this data in low renin hypertension and in age-race subgroups to make the following recommendation: that in younger and non-Black individuals, you should start off with a RAS inhibitor or a beta blocker, and in older or Black individuals, you should start off with a calcium channel blocker or a diuretic. And then once you've started off with an antihypertensive medication, then you add on, and the strategy they recommend is A or B plus C or D, and then A or B plus C plus D, and then if you're still uncontrolled, to add spironolactone or other diuretic. The data on difficult to control hypertension or resistant hypertension and spironolactone I will explore in a subsequent talk. Next slide. What is resistant hypertension? Resistant hypertension is the failure of 3 or more concomitant antihypertensive medications to lower blood pressure below 140/90. This is 30% of hypertension is resistant, but almost 70% of resistant patients are generally found to be low renin. And in these patients, it has been suggested that renin screening may be useful, especially if there is hypokalemia, family history of hypertension or CVA at age less than 40, adrenal adenoma, or family history of primary aldosteronism, or simply a blood pressure that's very high, greater than 160/100. Renal artery duplex is usually appropriate to rule out renal artery stenosis in difficult to control hypertensives. And FEO should not be considered randomly or without some guiding variables. FEO should only be considered if there is a proper triad of resistant hypertension, palpitations, and hyperhidrosis. Next slide. So I'll briefly talk about renal artery stenosis. In young women, renal artery stenosis is usually fibromuscular dysplasia, and angioplasty is indicated. In other patients, you may diagnose renal artery stenosis either via renal artery duplex or CT angiogram or MRA, or rarely ACE inhibitor augmented renal scan or angiography. So once you diagnose renal artery stenosis, who deserves intervention? Where is it likely to benefit? The patients likely to benefit would be if the resistive index is less than 0.8, if they have normal morphology, which means their kidneys look okay, but their renal function is reduced. And then if the size of the renal artery is greater than 7 centimeters, or if there's a recent decline in renal function. Next slide. So which of the following most likely contributes to the pathogenesis of salt sensitive hypertension in individuals consuming a low potassium diet? Increased aldosterone, increased activity of the NCC in the distal convoluted tubule, increased activity of the ENaC channel in the aldosterone sensitive portion of the distal tubule and collecting duct, or inhibition of the Wnt1 in the distal convoluted tubule. All these disorders with channels and the Wnt kinases, etc., are kind of like monogenic forms of hypertension, and they're relatively rare. The most common, as I said, is low renin hypertension, and low renin hypertension is usually salt sensitive, which is characterized by a tendency towards elevated aldosterone. And frequently you'll have a normal aldosterone, but in these patients, aldosterone should be low. So even a normal aldosterone is still a relatively elevated aldosterone. Next slide. We're following a 73-year-old man with stage 4 CKD, diabetes and hypertension. Office and home readings have always varied substantially from reading to reading. The patient states that his blood pressure always goes up because of traffic on the way to clinic, and he's not sure his home blood pressure cuff works correctly. You obtain ambulatory blood pressure monitoring, which shows marked variability, but most readings are within range. Which of the following is likely to be true regarding his blood pressure variability based on current data? Because most of his readings are within range, his blood pressure is considered well controlled. Although short-term blood pressure variability, as measured by ambulatory blood pressure monitoring, is worrisome, long-term blood pressure variability using office or home readings has not shown to be associated with the risk of cardiovascular events or mortality. Although long-term blood pressure variability using office or home readings is worrisome, short-term blood pressure variability as measured by ambulatory blood pressure monitoring has not been shown to be associated with the risk of cardiovascular events or mortality, or he's at increased risk for a major adverse cardiovascular event or death. And studies have shown that even short-term variability in blood pressure is associated with adverse cardiovascular events. Next slide. 55-year-old African-American man is referred for treatment of uncontrolled hypertension. He has CKD stage 3 with estimated GFR 45, urine protein to creatinine ratio of 1 gram per gram, strong family history of hypertension and ESRD. His blood pressure is 159/92, heart rate of 55. Medications include chlorthalidone 50 milligrams daily, losartan 100 milligrams daily, and amlodipine 10 milligrams daily. What is the best next action to adjust his regimen to control his blood pressure? Chlorthalidone should not be used because it's less effective at this GFR. An ACE inhibitor should be added for additional antitrypsinuric effect. A beta blocker is the most appropriate next agent, or spironolactone is the most appropriate next agent. So this patient is already on 3 drugs with good doses, so you should choose spironolactone as the most appropriate agent. Anyway, in this particular case, beta blocker would not be appropriate because his heart rate is already 55. The combination of ACE inhibitor and ARB is not recommended. And chlorthalidone is not effective in ESRD, and some people don't recommend using it in lower GFRs, like GFR less than 30, but a GFR of 45 is not a contraindication for use of chlorthalidone. In fact, it's very effective. Next slide. Okay, next slide. Primary hyperaldosteronism, I'm going to really run through this. Usually in adrenal adenoma, although bilateral adrenal hyperplasia is possible. In testing for primary hyperaldosteronism, the only medication that really needs to be held is spironolactone, and it should be held 4 weeks prior to measuring aldo and renin. Rest of the medications can generally be continued, and you can suspect if the plasma renin activity is low despite being on ACE or ARB. The diagnosis is made with a aldosterone of greater than 15 or an aldosterone to renin ratio greater than 20. You should do aldosterone suppression testing to confirm that primary aldosteronism is a viable diagnosis. And then for interpretation, these are the levels that are used post sodium load. You can do oral sodium load or intravenous normal saline. Even after you've confirmed that this may be primary hyperaldosteronism, you still need to confirm that this is a unilateral secretion, so adrenal vein sampling needs to be done prior to surgery. Next slide. Hypertensive urgency versus hypertensive emergency is a frequent clinical presentation. Hypertensive urgency implies acute neurological damage such as encephalopathy, papilledema, seizure, CVA, or cardiovascular compromise such as angina, MI, pulmonary edema, or aortic dissection, or other life-threatening events such as bleeding. Hypertensive urgency is marked hypertension without end organ damage. Previously normotensive patients may be symptomatic at much lower blood pressures compared to chronic hypertensives. You should not test for secondary causes during the inpatient admission. Goals are to, one way to treat hypertensive emergency would be to reduce by 25% in 1 hour to 160 over 100 over 2 to 6 hours, and then normalize in 48 hours. Next slide. Let's talk about cystic disease. Polycystic kidney disease is actually a common presentation in the CKD clinic. Extensive cystic disease leading to obliteration of the parenchyma and very big, usually palpable kidneys greater than 12 centimeters would be the typical presentation of ADPKD. If they have family history of ADPKD, but they don't currently have any signs of ADPKD, like they have a normal ultrasound, normal GFR, and no other signs and symptoms of ADPKD, you should use ultrasound criteria to determine if they are at risk for ADPKD. So if they're less than 30 years old and they have at least 2 unilateral or bilateral cysts, that would be consistent with the diagnosis of ADPKD. If they're 30 to 59 years, at least 2 cysts in each kidney should be present. And if they're greater than 60 years, at least 4 cysts in each kidney would be sufficient for a diagnosis of ADPKD. ADPKD can be sporadic, and you don't always see a family history of ADPKD. So you should always rule out extrarenal cystic disease, typically liver, and then other organs can be affected. And then blood pressure goal is less than 110 over 75. In patients who are 18 to 50 years old, or if GFR is greater than 60. Otherwise, it's 130 over 85. But I frequently see patients with ADPKD whom I do try to reduce the blood pressure to 110 over 75. Of course, sodium restriction, moderate protein intake, moderate phosphorus intake. ADPKD is associated with markedly elevated renin levels, so RAS inhibition is the preferred antihypertensive route. And then, of course, hydration, unless they have edema, but very few patients with ADPKD do have edema or CHF. Normal BMI is the goal, so weight loss is appropriate. Normal cholesterol, LDL of less than 100 or HDL greater than 50, and bicarb greater than 22. These goals should be applied in every patient with ADPKD. Next slide. So you should get an MR of the abdomen pelvis to calculate kidney volume to determine if tolvaptan is appropriate. Tolvaptan is now recommended in patients with Mayo Class 1C, 1D, or 1E. And after doing the first MRI, typically it can or should be repeated every 3 to 5 years to determine that in fact you have mitigated or prevented or decreased progression of disease. Next slide. This is how the classification looks like. Class 1B, Class 1A are not indications for tolvaptan, and if they're in Class 1C, 1D, or 1E, then you should start tolvaptan. Next slide. A 31-year-old man employed as a commercial airline pilot, recently diagnosed as having ADPKD, is evaluated in follow-up. He consults you regarding the need for an evaluation for cerebral aneurysms. Previous kidney ultrasounds have documented enlarged kidneys with numerous cysts as well as multiple hepatic cysts. His father died at age 68 years old from cardiovascular complications of kidney failure from ADPKD. There is no family history of cerebral aneurysm or subarachnoid hemorrhage. Blood pressure is 128/80. The abdomen shows bilaterally palpable kidneys. Remainder of the exam is normal. Laboratory studies show hemoglobin of 15 and serum creatinine of 1.3 milligram per deciliter. Which one of the following is the most appropriate next step in his evaluation? If he does not have a family history of cerebral aneurysm, should you still do an MRI? In this patient, he's a commercial airline pilot, so yes, MRI is still indicated, and MRI is the best way to assess for cerebral aneurysm, so the answer is magnetic resonance angiography. Next slide. So indications for screening would be family history of an aneurysm, previous aneurysmal repair, preparation for major elective surgery, including kidney transplantation, and high-risk occupations that includes airline pilots, and MRI is the preferred way to diagnose cerebral aneurysm, and this can now be done without gadolinium. Next slide. So simple tests usually are not worrisome unless the volume is greater than 500 cc's. If the volume is greater than 500 cc's, then drainage is probably indicated. And this 500 cc's pretty much means like a diameter of 10 centimeters, which is very rare, but I have seen cysts that large. And ultrasound reports usually do report diameter, not radius. So in category 2F, where you have thin septae or smooth, minimal smooth thickening of the septa or wall with possible calcifications that may be thick and nodular, you should do follow-up imaging to make sure that it's non-malignant. But consideration for surgery would be category 3, and category 4 would be very likely malignant and require surgery. So these would be all the category characteristics of category 3 plus enhancing soft tissue components that are adjacent to and independent of the wall or septum. Next slide. We'll quickly talk about nephrolithiasis. Kidney stones occur in 12% of men and 5% of women. This is a lifetime risk, and most stones are calcium stones, oxalate much greater than phosphate. 5 to 10% of the stones are uric acid, 10% are struvite, which is the magnesium ammonium phosphate stone, and less than 1% are cystine. Next slide. You should talk about diet with everybody with kidney stones. The first kidney stone is not worrisome, and you should not create worries for the patient with the first kidney stone, because likely they will not have a second stone. But if they have a second kidney stone, then yes, they need to discuss diet, they need to discuss prevention, and the 24-hour urine collection needs to be done to minimize stone formation. So these are risk factors for calcium stones. So you should drink plenty of water, because lower fluid intake is a risk. It increases urinary calcium and oxalate concentration. Lower dietary calcium is a risk. That might sound counterintuitive, but actually they need to have a normal calcium diet in order to bind the phosphorus and oxalate in the gut and get rid of them in the stool. Calcium that's taken by the oral route is absorbed in a very small percentage. But vitamin D would be deleterious if you have a stone history, because vitamin D will cause you to absorb calcium from the gut. But oral calcium is actually effective at lowering calcium oxalate and calcium phosphate stones. Of course, you should decrease oxalate intake. Normal potassium intake is important, and animal protein is bad for patients with kidney stones, so you should decrease animal protein intake. Salt is always bad, it's never good, and in patients with kidney stones also higher sodium intake is a stone risk. Carbohydrates in general is a stone risk, so decreased carbohydrate intake is very important. And vitamin C is basically an oxalate equivalent, so vitamin C should be avoided. Next slide. 24-hour urine collection is very important if the patient has had 2 stones. So basically, this is the way you would explain it. They get the 24-hour urine container from the laboratory, and then when they wake up at 7 a.m., they throw away the 7 a.m. urine, because that 7 a.m. urine is all overnight urine. And then after 7 a.m., they collect all urine from 7 a.m. to 7 a.m. the next day, including the overnight urine. They keep it on ice or in the refrigerator and bring it to the lab for analysis. Next slide. These are the reference ranges that you want to use in your analysis of the 24-hour urine collection. I won't go in detail. You should look at the supersaturation values as well, which tell you if they're at risk for calcium oxalate supersaturation, calcium phosphate supersaturation, or uric acid supersaturation. Patients in general should make at least 2 liters of urine. If they're not making 2 liters of urine, tell them to drink more water, unless they have edema, in which case they should not drink as much water. But 2 liters minimum is recommended. And so you would use calcium as a way to determine if they could benefit from hydrochlorothiazide. If their citrate is low, you can give them potassium citrate. And then sodium. The sodium level in the urine is actually not only useful for stones, but for hypertension as well. You can actually measure the sodium in the urine to determine if they're eating too much salt. And then you can tell them, this is proof that you're eating too much salt. You may think you're not eating salt, but the sodium in the urine is above 150, therefore you're eating too much salt. So cut down on your salt intake. Next slide. So as I said, for calcium stones, you should increase fluid intake, decrease protein and sodium intake, thiazide diuretics if they're at high risk, or if there's high calcium in the urine, potassium citrate if the urine citrate is low, and allopurinol if there's coexistent hyperuricasuria. Next slide. For uric acid stones, you want to raise the urine pH to greater than 6.5 with alkali, because this will markedly increase urate to uric acid ratio and decrease stone risk. So you should always remember the pH goals in patients with uric acid stone. Anybody who has a second stone or who has had a urological intervention to extract stones or to remove stones, either by a lithotripsy or by cystoscopy, the stones that have been removed should be analyzed so that we know the composition of the stone. And again, increasing fluid intake will be of benefit. Next slide. When do you consult urology? For less than 2 millimeter stones, only 5% will require intervention. In fact, I've never used urology for any stone less than 5 millimeters. If it's a 2 to 4 millimeter stone, 17% are reported to require intervention. The rest will pass spontaneously. 4 to 6 millimeter stones, only 50% will pass spontaneously, with average time to stone passage of 22 days. Spontaneous passage rate also depends on stone location. 48% for proximal ureter, 60% for mid-ureter, and 75% for distal stones, and 79% for uretrovesical junction stones. Next slide. So if you have urosepsis, acute kidney injury, anuria, or persistent pain, nausea, or vomiting, you should get urology involved. If it's a greater than 10 millimeter stone in diameter, or if they fail to pass the stone after a trial of conservative management, which would be alpha blocker and finasteride, then you should consult urology. And urology will determine the propriety for lithotripsy versus ureteroscopy. And for stones greater than 10 millimeters, generally ureteroscopy is better than lithotripsy. Stent may be necessary if there's ureteral injury, stricture, solitary kidney, renal failure, or large stones. Complex stones, which pretty much means greater than 2 centimeters, might require percutaneous nephrolithiasis. And if the patient is septic, then you should defer definitive treatment and place a nephrostomy tube or stent. Next slide. A 59-year-old woman is referred for evaluation of recurrent stones sustained over the past 15 years. She has a 10-year history of diabetes, hypertension, hypercholesterolemia, treated with metformin, lisinopril, and atorvastatin. She describes a steady increase in weight since her last pregnancy 30 years ago. She works as a computer programmer and notes little to no exercise except for walking from her car to her office. She tries to drink fluids during the day, but notes that she often leaves a bottle close to full at the end of the day. Her body mass index is 33, with a waist circumference of 90 centimeters. Her blood pressure at home is 140/82 millimeters of mercury. Which of the following does not contribute to her risk of stone recurrence? Insufficient urine volume does contribute. High BMI does contribute. Diabetes likely contributes. Physical inactivity, we don't really know. Next slide. There was one study which did not show a correlation between physical inactivity and kidney stone formation. Next slide. So that's the end of the talk. This is the 4th lecture in the 8 lecture series of board review. And then that will be followed by individual sessions that are devoted to interesting topics that I feel will stimulate minds and answer specific questions that do arise in the typical clinical setting. See you next time.